This is a special reprise of the pediatric grand rounds and also combined with adult adult medicine grand rounds about Zika virus. So I hope that I can give you a little overview of what's been happening with Zika virus and a little touch of what to expect in 2016. By way of disclosures, I have no research at present that is funded to study Zika virus, but we're in the hunt like everybody else is. So it's a wild chase for grant money at this point in time. So you're all aware that Zika virus has reared its head in the Americas, and in the past few months you've seen headlines like this about Zika virus concern spreads, especially related to birth defects. And of course, Texas reported the first case of Zika virus in the United States, so that at least they thought it was the first, in early January of this year. Arkansas has confirmed Zika virus cases. Louisiana, at the time of this, was investigating and has since confirmed imported cases of Zika virus. However, there is a well-known pediatric doctor in the Arklatex who says Zika is not our main threat. So you do have to be leery of what you read in the newspaper. It's here, this guy. The virus we're most likely to be infected with is West Nile virus. So I think that's a real important take-home point. West Nile, we know, is endemic here. Zika, we don't know yet if it will only be a visitor or will it come and stay, like, you know, Uncle Eddie who just got out of jail, okay? So we do need to, take things with a grain of salt. Dr. Bocchini is perfectly on target, of course, as always. Over the past couple of years, there have been numerous case reports in the biomedical literature, like this one, of Zika infection in a traveler who returned to Europe or Canada or pick a place from Brazil predominantly. And here is a case of laboratory-confirmed Zika infection in Europe. The patient developed fever, rash, edema of the hands and feet after returning to Italy from Brazil in March of 2015. This highlights that together with chikungunya and dengue, 3 major arboviruses are now co-circulating in Brazil, and that continues to be the case. Come on in, there's plenty of seats up front. I don't throw target eggs or anything. So these arboviruses, of course, represent a huge burden on the healthcare system in Brazil. And the serologic testing that was shown here, you can see that this patient had acute and convalescent serum titers of 1 to 160 and then 1 to 1280 for IgG and IgM specific to Zika virus, and a high neutralizing titer of 1 to 640 for Zika virus also, with little or no reactivity to dengue, Japanese encephalitis, West Nile, yellow fever, and chikungunya. And so those are sort of all the culprits that we're going to be talking about when it comes to the differential diagnosis in Zika virus. Of course, Zika virus associated with microcephaly is the major concern. And this is a case report that was in the New England Journal about a month ago. This woman, during the 13th week of gestation, she had high fever, followed by musculoskeletal and retroocular pain, itching, generalized maculopapular rash, and she was living in Brazil at the time. And Zika was suspected, but no virologic testing was performed. She did have ultrasounds at 14 and 20 weeks of gestation showing normal fetal growth and anatomy. However, she returned to Europe, and specifically Slovenia, where she was from, at 28 weeks of gestation, and a week later, her ultrasound showed the first signs of fetal anomalies. She was referred to perinatology and noted decreased fetal movements. At 32 weeks, her ultrasound confirmed intrauterine growth retardation, normal amniotic fluid and placenta, numerous intracranial calcifications, and microcephaly with moderate ventriculomegaly. And so this was the first case where there was actually documented tissue-confirmed evidence of Zika in the brain of an infant, because subsequently this pregnancy was electively terminated. Here is the autopsy findings in the brain, and you can't really see them very well, but there are white patches here of cerebral calcifications. You can see very little white matter here over relatively normal midbrain. Ventricle increased in size there, and again, more calcifications in an extremely abnormal brain. Immunohistochemistry, shown in green, is the positive cells here, show neurons infected with Zika virus expressing Zika virus proteins. and electron microscopy confirmed the presence of virus particles consistent with Zika virus. And so this case is very instructive, but it is still an N of 1. Subsequently, more cases have been reported, and the folks from CDC were able to confirm both placental and congenital infection in newborns and 2 miscarriages from tissue acquired from Brazil. I had the great pleasure to work during my PhD with Sharif Zaki, who is a master of pathology. And, of course, you've all read about the reports of sexual transmission of Zika virus, first in Dallas and now reported in other places and confirmed by CDC as a mode of transmission. So we'll talk a little about those also. So start with Zika, the basics. This virus was discovered in 1947 in the Zika forest. That's how it gets its name. This was a research station studying yellow fever, and there was a febrile rhesus monkey that was suspected to have yellow fever. They worked it up and, of course, then isolated a different virus that they named Zika virus. There have been sporadic outbreaks in Africa and Asia over the past 50 years, and I'll show you a map of how the virus has spread around. But the second message to take home is that the epidemic in South America is more than 10 times greater than all the other prior Zika epidemics combined. So it's a huge epidemic compared to everything else that's occurred previously. This virus is in the family Flaviviridae, and it includes dengue, chikungunya, St. Louis encephalitis, Japanese encephalitis, yellow fever, and also first cousin in the Flavivirus family, or Flaviviridae family, is hepatitis C. Very simple genome. It's a positive strand RNA genome. From a molecular research standpoint, it's one of the easiest viruses to work with because this basically is like a message sense piece of RNA, and the host transcription machinery picks it up and copies it very readily to make more genomic copies. In terms of the laboratory, Zika virus is considered a biosafety level 2 pathogen. It's spread by direct contact of an infected mosquito and now sexual contact. In the general population, sexual contact is believed to be a relatively minor route of transmission. Come on in, ladies. With respect to handling of specimens, universal precautions with gowns and gloves are appropriate for handling of Zika-infected tissues and fluids. Come on in. Come on, come on, come on. There's plenty of space. Come on, come on. Yeah, you can sit in the first class row right here. Zika virus-containing tissues and fluids should be handled in a biosafety cabinet. That's a routine precaution for any human pathogen. Remember, HIV is a biosafety level 2 pathogen. Hepatitis B and C are biosafety level 2 pathogens. So universal precautions for blood handling and human tissues are appropriate for use with Zika virus or suspected Zika virus. Of course, in the lab, we don't centrifuge without using closed containers because risk of aerosolization is important. And pregnant women and women intending to become pregnant should avoid work with Zika virus. That's a recommendation. However, the law protects women who are pregnant from discrimination, and I actually couldn't force someone who was pregnant not to work on Zika virus. So a very interesting piece of the law there. The vector is Aedes aegypti, and this is the vector also for dengue, chikungunya, West Nile, yellow fever, and Zika. So it's a pretty potent-looking mosquito that is endemic throughout the southeastern United States. And this animal feeds predominantly at dusk and dawn, but it can feed all day. And especially as we approach springtime, that will be the time for vigilance in monitoring our mosquito populations to see if Zika virus comes to visit or comes to stay. The female does the biting and transmitting, which I won't comment on. So the bottom line is if you want to control arboviruses, you must control the vector. That is the most important part. And in our country, we have the great privilege of having things like air condition that keeps mosquitoes out of our homes, and windows, most of us, screens on our windows, but we rarely open our windows anyway. And we have community-wide spraying for mosquitoes and monitoring of mosquito pools annually for West Nile and other viruses. And so adding to control of Zika virus is not very difficult for us here. It is quite difficult in South America and the tropics. A fascinating side note on Aedes aegypti is this particular strain that was developed in the laboratory, OX513A. It's a strain of mosquitoes that, in the presence of tetracycline, develops normally. But when you release it into the environment with no tetracycline, it can only survive a short period of time. And so the male mosquitoes can fertilize eggs, but the subsequent progeny of that fertilization are sterile. And so this experimental vector, has been used in some of the Caribbean island populations and is being studied in South America, has been for a couple of years, for control of dengue especially, because if you can release millions of mosquitoes carrying this genetic modification, in the island populations that have been studied, you can reduce the overall population of mosquitoes by about 90%. So a really interesting, fascinating area of study for real vector control. Whether this is helpful in other species that may control malaria and other things is, of course, more to do. This company is getting a lot of press because of this really unique technology. So as I said, Zika virus epidemics have occurred over the past 50 years. Here's Uganda, where the first isolations occurred. And you can see there were introductions into West Africa by these yellow arrows, and then subsequent spread throughout West Africa, and also down into back to Uganda and other places. Over the next couple of decades, there was spread of at least seropositivity for Zika virus into northern Africa and Southeast Asia. However, no evidence of great epidemics, and this is probably related to the fact that those early tests for Zika virus antibodies were not very good tests, so they lack specificity. They cross-react with other viruses that were known to circulate in these areas. However, by 2007, there was a very large outbreak for the time of Zika virus in the Yap Islands. And this graphic from Dr. Fauci's article shows Africa spread throughout Southeast Asia, and hop, skip, and a jump comes around Easter Island and over into South America. If you look at the travel that occurs from Brazil, this is part of the idea of what can we expect. This map is interesting. It's kind of a heat map showing where there's local transmission. So anything that's dark orange is year-round transmission of Zika virus. And the circles around these cities are an indicator. The size of the circle indicates how many travelers leave Brazil each year and come to those cities. So use New York City as a reference here. So annually, more than 300,000 people leave Brazil, either tourists coming back to the United States or business people coming back or immigrants, and travel to New York. Miami and Orlando each over 300,000 from Brazil. Cancun, a little less, only 150 to 300,000. The West Coast, a little less prominent of a site. And the importance of this data is helping us to predict the likelihood of Zika virus coming and establishing endemicity. Now, we know that annually imported cases of arboviruses, use chikungunya as a good example, occur. And in Louisiana, we diagnose anywhere from 5 to 10 cases of chikungunya virus annually, all of which are imported into our state from South America, mostly. At some threshold level, with an increasing number of importations, you have a great heightened increase of likelihood of establishing endemicity. And so this is really what is being monitored. You know, a few cases imported, not likely to establish. But when you start to get hundreds of cases imported, then you've got a much higher likelihood of transmission within the local environment from non-imported cases. So secondary spread, we'll call it. So go back to the Yap Island outbreak. It's a beautiful place. This isn't Nemo. I think it's one of his cousins. Beautiful collection of islands with about 8,000 people. They're very colorful people, and they wear colorful clothes. And you can see that here's the tip of Australia down at the bottom. Papua New Guinea is the big island there. And Yap is here between Guam and Palau, for those of you who remember your geography. Not I. So this outbreak in 2007 was reported in the New England Journal in 2009. As I said, there are about 8,000 people living on the island. You can't read this very well, but there were 185 patients who met the case definition for suspected Zika virus. Ultimately, 49 had confirmed, 59 had probable Zika, 72 had suspected, and only 5 did not have Zika virus disease based on serologic testing or PCR. So a fairly widespread outbreak, and in that epidemic it was estimated that about 20% of the population got symptomatic Zika virus, which is consistent with what we know as the likely rate of transmission, of disease. Here's the epidemiologic curve showing probable cases in the pale color and confirmed cases in the dark. This started in early April and lasted until early July, so over about a 4-month period of Zika virus activity. Here's the age distribution, and you can see that children were not spared compared to adults. Both were had equal or near equal rates of infection and disease, or probable cases compared to confirmed cases. And that's not surprising because there's very little or no previous herd immunity to Zika virus in that population. The case reports give us probably the best compendium of clinical symptomatology on Zika virus that's been reported to date. Remember, this was the largest outbreak up until its time, and it happened in a place where you could actually study the population. 90% of patients had a macular or papular rash. 65%, or 2/3, had fever. Arthralgias also in 2/3. Conjunctivitis in about 55%. Myalgias and headaches in about half. Retroorbital pain, 39%. Edema and vomiting, lower percentages, less than 20%. So, and this included subjective fever as well as measured fever. So this symptomatology, particularly rash, fever, arthralgias, and conjunctivitis, is beginning to hone into a little bit of specificity for Zika. But these symptoms overlap with all the other guys in the same boat, right? Chikungunya, dengue, especially primary dengue infection. Hopefully you could distinguish yellow fever as it developed its course. Wouldn't look like this. So after 2007 and up until about 2014, Zika virus kind of slowly marched across the islands of the South Pacific. And you can see, let's see, here is Yap Island, I believe, is there. Here's your Australia reference, the tip of Australia. And we'll march all the way down to Easter Island. So the graphic I'm going to show you is going to give you colorful diagrams to show you where dengue was, Zika virus, and chikungunya over this time period. And so we're going zigzagging across 2007, 8, 9, 10, 11, 12, 13, 14 in the bottom right. And you can see that the circles indicate different dengue serotypes that were present in 2007, continued in 2008, 10, 11, and 12, and chikungunya reared its head in 2013 and progressed across the islands in 2014, and Zika virus followed right on the tail of the chikungunya. A little bit of Zika virus in 2013 and also Zika virus in 2014, just prior to the arrival of chikungunya in South America, followed by Zika in South America. Now, whether that is simply an association or causatively related, we really don't know yet. Is it possible that prior infection with chikungunya somehow facilitates transmission or infection or disease with Zika virus? We don't know the answer to that, but from a biologic perspective, we think it's plausible, especially given what we know about dengue virus, when the first infection is not usually so bad, but subsequent infections can be horrific. So the immunologic crosstalk between these viruses is still an important area of research. Over that 50 years since the discovery, or now 60 years since the discovery of Zika virus, the virus has also evolved, and the original African strains are shown here compared to, in this phylogenetic tree, the more recent South Pacific and South American strains of Zika. So we are seeing specific evolution away from the African strains. That may be part of the reason we're seeing larger outbreaks and more rapid spread. Again, an area of research that's ongoing, but a lot more questions than answers. Perinatal transmission of Zika virus was described in French Polynesia in December of 13 and February of 2014. You can't read this, but the graphic is basically a description of two mother-infant pairs that mom had disease consistent with Zika virus right around the time of delivery, a few days prior to delivery or up to a week prior to delivery, and her Zika virus was confirmed. Both moms had PCR evidence of Zika virus in their blood. They had mild rashes, a little bit of fever. Both moms breastfed. Their breast milk was found to be Zika virus positive also, and their infant subsequently developed disease consistent with Zika virus. So breastfeeding transmission and or perinatal transmission at the time of delivery was highly suspected from these case reports in the South Pacific. And as you're all aware, last year in the fall, the Brazilian health officials declared a national emergency because of this unusual increase in newborns with microcephaly. The bottom line is that what they reported was a 20-fold increase in microcephaly rates from about 6 per 100,000 up to about 100 per 100,000 in a 5-year period. So a very dramatic increase in the number of cases of microcephaly, coincident with chikungunya coming in, Zika coming in, and of course in a very stressed healthcare environment. So this was labeled a possible association between Zika and microcephaly and reported about 2 months ago by MMWR in collaboration with colleagues in Brazil. And in this case, these are phenotypic findings of 35 patients enrolled in a small study by the Medical Genetics Society of Brazil. Maternal rash was reported in about half of the moms during the first trimester. And this is looking at babies with microcephaly. Head diameters were small, smaller than the 3rd percentile, or more than 3 standard deviations away from the mean, and about 1/3 of them between 2 and 3 standard deviations from the mean. Other defects, especially ophthalmologic, were also described in abnormal fundoscopic exams. These babies overall had good weights, and they were predominantly term babies. So this at least brought forth the possible association between Zika and microcephaly. On neurologic exam of these babies, about half had some abnormalities neurologically, especially hypertonia and spasticity, hyperreflexia, irritability, and about 10% had seizures. On neuroimaging, calcifications were present in 3/4 of the babies, and ventriculomegaly in almost half. And so this really helped us hone in the neurologic syndrome that we were looking for in association with Zika virus. And this same folks, or about the same time, was reported macular atrophy in a child with microcephaly with confirmed Zika virus infection. So putting onto the spectrum of congenital, what's evolving as congenital Zika virus embryopathy, especially encephalitis, including the changes in the optic nerve. Less than a month ago, just a couple of weeks ago, CDC reported Zika virus infection among U.S. pregnant travelers. Between this time period of August to February, they had done over 250 blood tests on pregnant women, 9 of which had confirmed Zika virus infection. And the results of those pregnancies are shown here. Early miscarriages, there were 2, and 2 elective terminations. All of these first 4 were all associated with first trimester Zika virus infections, and I'll give you a few specifics in a minute. 3 live births, 2 of which were normal, and 1 had severe microcephaly. That one with severe microcephaly was also associated with first trimester infection of the mom, and 2 babies are still gestating, and at 18 and 34 weeks gestation are now 20 and 36 weeks. What's interesting in their report is a couple of things. One patient was reported a history of travel to a Zika-infected area at 11 to 12 weeks gestation. At 20 weeks gestation, ultrasound showed absence of the corpus callosum, ventriculomegaly, brain atrophy, and fetal MRI demonstrated severe brain atrophy. And that was one of the elective terminations. Another patient in her 30s gave birth to an infant at 39 weeks gestation. Head circumference was less than the 3rd percentile. She had lived in Brazil until 12 weeks into her pregnancy. At 7 to 8 weeks gestation, she reported fever, rash, arthralgia, headache. Molecular and pathologic evaluation of the placenta demonstrated Zika by RT-PCR and immunohistochemistry. The baby had hypertonia, difficulty swallowing, seizures, paraventricular scattered calcifications, and an abnormal fundoscopic exam However, hearing screen was normal, and that infant went home with severe disability and gastrostomy feeding tube. And the other case they report is a woman in her 30s, traveled to a Zika-affected area at 15 weeks gestation and had a disease consistent with Zika at 17 to 18 weeks gestation. At 40 weeks, she delivered a normal, healthy term baby with no obvious problems. And so, again, highlighting that the spectrum of this disease is not predictable just because mom has symptomatic infection. The most recent publication just came out this week in the New England Journal, and this is a prospective cohort study of pregnant women who presented with a rash within 5 days of presentation. So these are 88 women were enrolled between September of 2015 and February of 2016, but rash was the only symptom required to be enrolled in the study. Very interesting findings. So 72 or 82% were Zika virus positive in blood, urine, or both. Median gestation was about 20 weeks at the time of the rash illness. Rash lasted about 4 days, no different than the presence of rash illness in the non-Zika infected women. Arthralgia, myalgia, headache, fatigue, edema, and fever were very nonspecific. That is, even women without Zika had many of these symptoms, and so you couldn't tell Zika from non-Zika based on any of these symptoms. Among Zika-infected moms, less than 30% actually had fever. So looking for a febrile illness, if you had started that as one of your admission criteria into the study, you would have missed 70% of the babies with Zika. However, what was more specific were conjunctival injection, lymphadenopathy, and specifically a maculopapular rash, not a papular rash. And those are really the only symptoms that gave you specific distinction between Zika-infected moms and Zika-negative moms. 12 of the 42 infants with Zika-infected moms had abnormal ultrasound findings, so about 29%, almost a third. 5 had in utero growth retardation, 4 with cerebral calcifications, 2 had oligohydramnios, and 2 had intrauterine fetal deaths. So this report is also, again, very instructive because it's a large collection of cases. It shows us a relatively high sort of penetrance of infant disease associated with maternal Zika infection. It tells us a lot about the timing of maternal infection and the likelihood of effects on the baby. So here's some pictures from that article. Here's mom's rash on her face. It was also on her trunk and her legs. You can see conjunctival injection here. Fairly mild, though, and would be easy to miss if you didn't take a good look in the eyes. Here's rash on the legs. Here's rash on mom's belly with a big handprint right on it from where somebody pushed down. Gently, I would presume. And here is the findings of the ultrasound based on week of gestation at the time of infection. So we started at 6 weeks gestation was the earliest, out to 35 weeks. Those in the pale color were normal findings on ultrasound. Those in dark colors had abnormal findings. And I'll summarize those for you in a minute. So you can see early infection associated with abnormal findings, but also many late infections associated with abnormal findings. Most of these on the right side are not as severe, but they are concerning. So there are things like there were 2 late in utero deaths or stillbirths, one at 38 weeks, one at 30 weeks. Microcephaly was reported from infection as late as 26 weeks gestation, reported having microcephaly at 35 weeks at delivery. Cerebral calcifications also occurring with infection as late as 27 weeks and delivery at term. So late infections can also have some significant side effects. And one infection was out here at 35 weeks infection. Baby delivered at 40 weeks. Baby had anhydramnios and intrauterine growth restriction, despite a very late pregnancy infection. So the other thing that this article really gives us is better definition of what the whole spectrum of disease is, because this is not isolated microcephaly in these babies. It's in the context of in-uterine growth restriction. Only one of the babies with microcephaly was at an isolated finding. All the others were in the context of in utero growth restriction. So now we're thinking of much like our congenital rubella syndrome, right? It's a whole spectrum. It includes here predominantly neurologic disease. That's a little different than congenital rubella syndrome, and but it is overall intrauterine growth restriction. This table I encourage you to go look at because it details all of the 12 affected fetuses based on their ultrasound data and the findings at birth. And this graphic shows you the biparietal diameter over compared to gestational age, and what you can see is that 3 of these babies in particular were well below the 10th percentile and subsequently in less than the 3rd percentile, which is our definition of microcephaly in this particular cohort. But you can see most babies had normal head sizes. Only 3 of the 12 who had abnormal ultrasound findings had small heads. Again, giving us the idea that microcephaly may just be really a tip of the iceberg. It's easy to identify a baby with microcephaly. However, there are a lot of babies with abnormal ultrasounds who have normal head size. So where can we find Zika virus? We know it's mosquito transmitted. This graphic in clinical virology shows you the timing of viremia and also saliva shedding in a group of patients. This is for 182 patients with saliva, blood, or both, tested by RT-PCR. And you can see that the peak, about 25% of those patients had viremia and salivary excretion on day 2, and that waned down to only a few percent patients, or small number of patients after day 5. So the period of viremia, about 5, 6, 7 days, somewhere in that range. Whether viremia correlates with symptoms or salivary shedding, not a whole lot different. These patients had fever, rash, malaise, conjunctivitis, and arthralgia, much like the nonspecific symptoms we looked for previously at the time of RT-PCR positive saliva and blood. Zika virus can also be detected in the urine, and this graphic shows 6 cases where there were paired or timed collections of blood and urine, and you can see that viremia dropped to undetectable by about day 5 for those patients that blood was available. However, viruria persisted for some patients easily out to 2 weeks, and for some patients maybe out as far as 3 weeks. A difficult picture to deal with, because if it's an acute infection and we get over it and we're not shedding it anymore, then that's good. However, this virus seems to persist and be shed a little longer. Importantly, the urine findings may correlate with semen findings, and sexual transmission may occur after the period of viremia. Again, many question marks there yet to be studied, and important question marks to help us understand sexual transmission of Zika virus. So with all of this going on, the CDC has been fairly forthcoming with guidelines for pregnant women, for monitoring of babies, for monitoring of travelers who've visited Zika endemic areas. And a lot of this is based on the little bit of information we have and the lot of information we don't have. So the guidelines clearly have to err on the side of caution and protection of moms and babies. And that's what you'll see throughout these guidelines. And I'm not going to go into a lot of detail about these, but basically pregnant women who visited a Zika endemic area and have disease consistent with Zika should be tested. If they don't have clinical illness, the initial recommendation was just continue with fetal ultrasound to look for microcephaly and intracranial calcifications. If those were present, then test for Zika. That will likely evolve over time, and it has already evolved, in fact, over the past month. When it comes to testing of infants, this is not unlike our routine testing for other congenital infections. If babies show microcephaly or in utero growth restriction, and there's a risk, or mom has traveled to a Zika endemic area, then you'd want to do Zika virus testing and other evaluation, both of the infant and the mom, and report those cases for long-term follow-up. At this point, there is no treatment available. Treatment is supportive care, much like most of the congenital infections we know and deal with. This reference is a very interesting one, and I've sent it to the pediatric residents previously, and I can make it available to those of you on medicine. It's an article, a review of rash syndromes, and it does a very nice job of breaking down the common things that we see: hand, foot, and mouth, parvovirus, enteroviruses, and EBV, CMV, etc., compared to the mosquito-borne viruses that have somewhat kind of loosely syndromic rash and fever, rash and arthritis, rash and encephalitis, or other syndromes. Now, I think you kind of have to take this table with a grain of salt. It's got a lot of things on it we don't see here. Barma forest virus, I don't think we've seen in the United States yet. And a young virus we don't see routinely here. But this is on a backdrop of almost 600 arboviruses and hemorrhagic fever viruses that are known to exist. So this really pares it down to the things that are possibles. What's important about this article is it has some very, very good color pictures of rashes that are common. It's got measles, it's got rubella, it's got parvovirus, it's got enterovirus rashes, it's got a whole compendium of color photographs. It makes a great board review for those of you who still have to take boards, which is pretty much all of us. It also has this nice table breaking down your arboviruses, again, loosely by syndromes: rash and arthritis, rash fever, rash encephalitis. Here's our West Nile virus, tells you where it's endemic, what spreads it, its incubation periods, and the laboratory diagnosis. So a good reference article to keep for your studies. Now, CDC has also updated their guidelines for caring for infants and children with possible Zika virus. What they reported in this one are a few facts that are interesting. Number one, always remember, death is rare following Zika virus infection. Okay, so this is not Ebola virus. It's much like West Nile virus, with the exception of that specific entity of Zika virus embryopathy, a neurologic disease. 2 cases of female teenagers who died related to Zika virus were reported. One of those 2 had sickle cell disease. This may give us a clue that our chronically ill patients and our compromised patients may be at higher risk of complications. Again, not much in the literature, not much being reported out of South America at this point. And finally, Guillain-Barré, you're hearing a lot of press about it, is again associated. Causal links are not yet established. No cases have been reported in children. But remember, Guillain-Barré is associated with probably 100 different viruses already. And it's likely, if there is an epidemic of Zika virus here in the United States, we will see more cases of Guillain-Barré associated with Zika. In South America, it's a very challenging situation because they are seeing a lot more Guillain-Barré syndrome. It can be very severe, can require ventilators, and I've heard folks on the television recommending that every hospital in South America should buy 5 or 6 extra ventilators to be ready for these cases of Guillain-Barré syndrome. And whether that's really necessary or not is not clear, but it indicates the heightened awareness and concern about Guillain-Barré in the adult population especially. Okay, so we reviewed that. So the bottom line is that there are still many, many questions, and there's a lot more questions than we have answers at this point in time. We don't have any clue why Zika is able to cause congenital infection when all the other arboviruses are not. As I alluded to, the technology to study recombinant viruses in this family of negative strand RNA viruses is not difficult. And so we may be able to get some answers to this by making chimeric viruses. Does prior exposure to other viruses portend a worse prognosis or portend fetal disease or other complications? Again, unknown. And that's an important question yet to be answered. Can our Hep C meds, which are first cousins of this virus, or other flavivirus meds be used to treat Zika virus infection? We know there are several companies, one company that I'm in discussions with, who has a potent antiviral that is broad spectrum, and it is already published to improve survival in Marburg, Ebola virus, yellow fever virus, and they just published this past week the ability to improve survival in Zika virus infection in an immunodeficient mouse model. So there are drugs in the pipeline that our government is heavily investing in their development, especially rapid development, to try to find some agents to treat the virus. But then you have to move to the next question: are they safe for use in pregnancy? That's really where the rubber meets the road. Is there a reservoir in nature that's fueling this epidemic? Is that part of why this epidemic in South America is so different than the prior epidemics? Again, not clear. West Nile virus, we know many mammals can be infected with West Nile virus. You can measure the serology in deer and possums and raccoons, all the things we routinely eat. But is there a reservoir that's fueling the epidemic? We don't really know the answer to that. The fauna and flora of South America are much different than what we have here. Primates are a good example. That they have New World primates, most of them living in their backyards. And finally, what will happen in the United States? Again, as I said before, that remains to be seen. Zika has already begun to visit, but whether it will stay is really going to be difficult to predict at this point in time. Our expectation is we will likely see Zika virus cases. Whether there is sustained transmission and endemic potential over time, like we saw for West Nile over the past 15 years, is not clear yet. So time will tell. At that point, we'll take you back to what the Yap Islands look like, a beautiful oasis, now probably Zika virus free, so it might be a good place to go. I have heard of one woman who lives in Louisiana who's pregnant and decided that she was better off avoiding Zika virus, so she's going to spend the rest of her pregnancy in Montana. That sounds like a great idea, but probably not practical for the vast, vast majority of us. So with that, I'll stop and answer any questions or feel any comments or discussion. Dr. Bana.
With the presence of the virus and the saliva and memory in the breast milk, what would be the need for the mosquito then, even if you eradicate the mosquito?
Right.
Right.
So Dr. Bana's question is, if there's virus in saliva and also breast milk, why do we really actually need the mosquito? Or conversely, will eradicating the mosquito or reducing it reduce the transmission of this virus? So it's not clear yet that breast milk or saliva has high enough concentrations of virus to cause transmission to the baby. Of course, we know transmission of viruses from mom to babies is very common. Think about herpes virus number 6, mom's saliva. If baby gets kissed by mom, which we hope it will, it's going to get the virus, right? But whether that's with Zika is enough to transmit the virus is unclear. Mm-hmm. Right. So sexual transmission, right. So again, sexual transmission is confirmed, and that could happen. Whether that could sustain an epidemic depends on how many sexual partners you have, for practical terms. So again, not clear that would sustain transmission out with the absence of mosquitoes. Yes?
How do we know that this hasn't been popping up in the U.S.? And, if I had any of those symptoms, I probably wouldn't go to the doctor.
Okay, good question. So how do we know Zika hasn't been here previously or intermittently, and the symptoms are fairly nonspecific? Most people get over them within a week, and they may not even go to the doctor. That's a very reasonable question. So based on the seroprevalence studies that CDC's been able to do in the past year or so, there's not evidence of Zika virus endemic in our population to any large extent. And what they do see is some cross-reactivity with other viruses, dengue, chikungunya, etc. So we don't believe Zika's been here. You're right, the symptoms are self-limited. Most people who have Zika virus fever, which is probably going to be about 20% of those who get infected, are going to get over it in 4 or 5 days, a week, and be done with it. 80% of people who get infections, and I failed to mention this, have no symptoms at all. So asymptomatic infection is the rule or the predominant situation, much like West Nile virus. And so I encourage you to think about, when you're talking to your patients about Zika, use West Nile as a comparison, because that 80-20, 80% non-symptomatic, 20% symptomatic is consistent for both viruses. Dr. King.
Brazil has any idea about using infected mosquito control, or the only effective?
Right. So Dr. King's question is related to mosquito control in Brazil and other parts of South America. I have a nephew who lives in Brazil, and he said that the military has been enlisted going door to door to every house around, thousands and thousands, to help get rid of standing water, do the basic things that we all know of, control the places where mosquitoes breed. Spraying for mosquitoes is occurring in some urban populations in South America, especially in the bigger cities of Brazil. But the economic issues down there also trump the ability to do such sort of basic things that we're used to here. So there is some, but it's to a limited extent. And control of the breeding places. Remember, even just a cap from a Coke bottle with a little bit of water in it, it's enough for a mosquito to produce, thousands of larvae. So, stick with the basics. Dr. Bana.
A baby born in an infected mother, and at birth the baby was fine completely. The extent that this later, particularly mother was infected in the first pregnancy.
Right. So Dr. Bana's question is, if mom's infected late in pregnancy and the baby's born normal, is there a chance that the baby could have developmental delays or other problems because of that infection? I think the answer has to be, it's possible. Based on the data that was just published on the New England Journal article, some babies with very late infection do have symptoms of disease. Some had, even severe complications related to Zika. We know brain development continues well after birth, and neuronal populations, if infected at the right time, may continue to have damage due to Zika virus. Again, yet to be worked out. Animal models are working on that question. But I think the possibility is yes. The probability is not unreasonable.
When we tell the mother the baby is not going to get it, just like we tell the HIV.
Right. So when can we say definitively we've ruled out Zika virus or any complications thereof in a mom who had symptomatic disease? We don't know the answer to that yet. We don't know the answer. My guess is that it's not going to be as long as HIV, 5-6 months after delivery that it takes to rule it out. But again, it's related to the timing of infection, looking at brain growth, head development. Could babies' head circumference, fail to progress normally after birth because of a recent infection? We don't know the answer to that yet.
PCR does not help in the baby?
PCR may be helpful in the baby, but based on the fetal data that's been presented, there's evidence that you really have to know what's happening in the brain, and it's not so much in the bloodstream. And of course, we're not going in biopsying, brains to look for this. So that's a little more challenging. Whether CSF PCR could be helpful, again, an unknown question at this point. But that may be part of the algorithm to come. Diana? Right. So Dr. Bienvenu's question is related to, if a baby is infected early in life from mosquito transmission, what's to keep it from having, issues and especially brain development issues? And at this point, not a whole lot. I mean, there are vaccines under development. Some have been in development, and that's accelerating. Maternal antibodies may help protect. Unknown questions. Antivirals may be available at some point in the next couple of years. But at this point, we really don't have the ability to predict that baby's outcome or alter it. Right. So the question from Dr. Bienvenu is there an increase in reported abnormal brain development from postnatal infection of the baby? And the answer is not reported. I think there's so much panic and fear about in utero, people aren't spending the time to look, for those things yet. And they may not manifest till the second year of life, even though the damage was done earlier. Yes.
I'm sorry if I missed this, but did you know anything about once you've been infected, being a carrier or developing immunity?
Right. So the question is about being a carrier or developing immunity to Zika virus. We know that viremia doesn't last very long. Our assumption is that primary infection gives protective immunity downstream. So, but that's still yet to be proven. We know with dengue it's only partial, and it highlights the bad cases. But our assumption will be this is more like West Nile, that once you've been infected and had primary infection, you should have durable, lasting immunity going forward. Whether that is enough to protect a baby in a subsequent pregnancy, unknown question. Reasonable to assume that it will, but look at our case of congenital CMV. Some moms have reactivation that leads to disease despite pre-existing immunity. This virus, though, is an acute virus. It's not a persistent like CMV. So it's going to be more like the case from a scientific standpoint, we think of rubella-like syndrome, acute disease. Yes?
Have they thought of any models or have thought about how this could possibly spread with the Olympics being there in the summer?
Right. So the question is related to the Summer Olympics coming to Rio, and that is a big issue on everybody's radar. CDC has been running scenarios on this for almost at least 6 months now to predict the likelihood of, again, at critical mass of imported cases enough to establish autochthonous or local transmission. And that is definitely a concern. It's hard to, I mean, there are people who've already said they're not going because they're afraid of it. But again, for adults who are healthy and non-pregnant, this is a nuisance virus more than it is a critical problem. For athletes who are worried about their performance, probably their best thing to do is go down there now, get infected early and get over it, and then, keep up your training, right? I mean, you sure don't want to have Zika disease at the time you have to perform in the Olympics, right? And run a marathon with Zika virus on board, So that's a right. Yeah, global spread is already occurring, and it will likely occur much more with travelers out of Brazil after the Olympics. Yes.
I think one reassuring thing is you said I know microcephaly is not the only possible side effect, but the prevalence is 5 in 100,000. It's only up to 20 in 100,000. That's like less than
100 per 100,000, right? So it's 0.1%. Yeah.
Now it's 100 and what is 20?
It was 5 per 100,000. Now it's 100 per 100,000. So it's a 20-fold increase. So 100 per 100,000, that's 1 in 1,000. That's as common as congenital CMV in this country, right? Okay, thank you all very much.